Hello, my name is Ronnie Fass, and first of all, I wanted to say how honored I am to receive the 2023 Aldo Torsoli Foundation Research Award. Um, what a great honor it is, and I really appreciate both the Torsoli Foundation and Rome Foundation for selecting me as the recipient of this prestigious award this year. I was asked to cover in a short presentation my academic journey. The problem that I had, of course, is that I've had almost 30 years of academic career with more than 450 publications over time. Um, and so condensing it into a very short presentation would have been very difficult. So I'll try and do my best. First of all, I started my career in 1996 at University of Arizona and Tucson VA Medical Center as a young faculty member. The building that you see in front of you is the main building at the Tucson VA Medical Center. The guy on the left side is me. This is how I looked when I started my career at University of Arizona as a young faculty member. Immediately after arrival, I've established the Neuroenteric Clinical Research Group. And the group was very successful from many academic aspects, all the way from achieving funding from different sources, all the way from societies to federal funding, drug companies and device companies, as well as other sources. In addition, we've embarked on many research projects, primarily in the area of esophageal disorders, basic and clinical research projects. And we were able to bring almost all of them into fruition and publish them in high impact journals. These are my mentors, the two that were very important in shaping my career. Dr. Richard Sempliner was my mentor when I was a resident in internal medicine at University of Arizona, and also served as my mentor when I came back to University of Arizona as a young faculty member, and served as an important mentor during my first years as a young faculty member. His background is very interesting. He was a very successful hepatologist that later in his career decided to convert and become a Barrett's esophagus expert. And he was also very successful in that area. Dr. Emran Meyer also served as an important mentor who specifically shaped my thinking process. It helped me to incorporate a lot of the concept that he helped me to understand early in my career into my different research projects. Dr. Emran Meyer served as my mentor during the time that I was a GI fellow at UCLA. And we kept in touch after I started as a young faculty member at University of Arizona. One cannot mention his career without those that helped him to be successful. Beside the fact that I had many collaborators, and to many of them I have to thank for their help and support during my long career, local collaborators from my own institution or national and international collaborators. But specifically, I'd like to mention the research fellows, and those were pivotal to the success of my career. I've had many of them, all the way from young students, pre-med students, residents from internal medicine, fellows from different areas, but primarily from gastroenterology, and young faculty members. Here you can see two research fellows that spent time with me at University of Arizona. On the left side, you can see Professor Tomás Navarro Rodriguez from Brazil, who is now one of the leading experts in the area of neurogastroenterology and motility in Brazil. And then on the right side, you can see Dr. Anita Gasharowska, who is a professor and head of her GI department in Łódź, Poland. Maybe you don't know, but I started my career in the area of irritable bowel syndrome. I later gravitated to the area of esophageal disorders. You can see some of my early publications in the field of irritable bowel syndrome, including focusing on sexual dysfunction in these patients and then assessment of sleep disturbances. I was also involved, as you can see at the top, in evidence and consensus-based practice guidelines for the diagnosis of irritable bowel syndrome, a paper that was published in what is now JAMA Internal Medicine. Now, I'll take this opportunity and show you some of my areas of interest that I've spent many years of my career in studying them and studying different aspects of them. One of my important areas was symptom generation with the focus on esophageal symptom generation using a variety of esophageal stimuli. This is one of the early studies that I published in gastroenterology. And in this study, we looked at two types of stimuli, chemical stimulus and mechanical stimulus. The chemical stimulus was, in fact, developed and validated by myself. And this is some type of variation of the Bernstein test. And on the right side, you can see the mechanical stimulus that I work with. And I was probably the first person to work with balloon Baristat in the esophagus of patients. The study also looked at physiological response of the esophagus to balloon distension, as you can see here, and reported for the first time that balloon distension can also result in heartburn, something that was not known, surprisingly, till that time. The feeling was that only acid can lead to heartburn. And in the case of balloon distension, it can only lead to chest pain. Subsequently, I've done many studies that looked at esophageal sensation in the esophagus. For example, trying to understand the differences between older and younger patients and differences in symptom sensation. Also, can you modify symptom sensation? And I use the Barrett's esophagus as a model for that. And if you see at the bottom, this is actually a table that I published in the Journal of Clinical Gastroenterology. And this table is summary of many of the studies that I've done over time, assessing different sensory stimuli on the esophagus and their impact on symptom sensation. I used a variety of study protocols in order to assess central factors that can modulate symptom perception. In this study, I looked at the effect of stress on symptom generation. This is another study. It looked at another important central factor, which is sleep deprivation, demonstrating the importance of sleep deprivation on symptom perception. Interestingly, during the studies that I've done with using different type of esophageal stimuli, I was also able to identify that stimulus and site-specific can induce hiccups in the esophagus, a study that is still considered today as a pivotal trial in the area of hiccups. Further information about symptom generation was work that I've done in the area of non-erosive reflux disease, demonstrating that many of the symptoms that patients report are actually generated from reflux stimuli that now we call them weakly acidic reflux. Now, this was reported already before impedance and pH were available. And one of the important studies that I feel very proud of is the fact that we even looked at dietary nutrients that may influence perception of intraesophageal acid reflux events. And we found out that cholesterol in particular is important in symptom generation of patients with GERD. Later, I started to focus on functional esophageal disorders. And this was, I thought, was a very kind of important direction for somebody who's already interested in symptom generation. Functional esophageal disorders obviously raise many challenges related to symptom generation. One of the early studies that I've done in patients with non-cardiac chest pain showing the value of the omeprazole test in this patient population in identifying GERD as the underlying cause. And here you can see a variety of research projects that were done in functional esophageal disorders, specifically in non-cardiac chest pain, all the way from assessment of GERD in this patient population, the role of endoscopy, as well as esophageal motility assessment. I think one of my important pieces that I wrote at the time, the title was Functional Heartburn, the Stimulus, the Pain, and the Brain, which was published in Gut with Gervais Touga. And this paper really outlined what was the understanding at that time of the mechanisms that lead to functional heartburn. And I felt it was the right way to summarize much of the work that was done in that area at the time and try to organize it so it will be clear what should be the next steps in that field. This is a work that I've done in functional heartburn, trying to identify a variety of factors that could be associated with this patient population. And recently, I wrote with Dr. Zarbib and Dr. Wayali, the AGA clinical practice update on functional heartburn. I was also involved with ROM4, Functional Esophageal Disorders Committee. I served as a chair. The co-chair was John Pandolfino. And I think it was very important for me, as well as the other members of the committee, to introduce reflux hypersensitivity as a new functional esophageal disorders. Until that time, all the other ROM committees stuck to 4 functional esophageal disorders. But we all felt, all members of my committee, that it was time to introduce reflux hypersensitivity as a new functional esophageal disorders. And I'm very proud of this as part of one of the important products of our esophageal disorders committee. And reflux hypersensitivity remains a disorder that stood the test of time and likely will continue and be part of the functional esophageal disorders. This paper, in fact, summarizes all the reasons and why the committee felt that reflux hypersensitivity should be a new functional esophageal disorder. I was not shy. I didn't shy away from doing studies using alternative and complementary medicine. And here are just a couple of them. For example, this is a study that looked at the value of acupuncture in patients with refractory GERD. And the other one is a study that looked at the effect of Joe Ray. It's a type of energy healing in patients with functional chest pain. Another area that I focused on was studying non-erosive reflux disease. For me, this patient population, which were the largest group of GERD patients, was not only important because of the size of it, but because, to me, it was very it was pivotal to understand why these patients develop symptoms despite the fact that they don't have esophageal inflammation, at least for the naked eye. One of the pieces that I wrote, which I thought was extremely important for my career and in trying to put together the knowledge that we had by that time on non-erosive reflux disease, is this paper called Non-Erosive Reflux Disease, Current Concepts and Dilemmas, which I published with Dr. Brian Fennerty and Dr. Nimish Vakil in the American Journal of Gastroenterology. A follow-up paper similar to that was published then 9 years later in the Journal of Neurogastroenterology and Motility, which now I serve as the editor. Both of these very detailed reviews are very commonly cited, but for me, it was very important to use them as a jumping board for further understanding what research should be done in the future. This is a study that we compared patients with non-erosive reflux disease to erosive esophagitis. This is another study showing the extensive overlap in relation to esophageal acid exposure among the different phenotypes of GERD. And this is a study that looked at the distribution of esophageal acid exposure of the three phenotypes of GERD, comparing the type of distribution among these groups throughout the esophagus. I also spent a lot of time looking at the impact of treatment on patients with non-erosive reflux disease, specifically as compared to those with erosive esophagitis, and trying to understand why there is a difference. This is a paper that I wrote about the natural course of gastroesophageal reflux disease. Gastroesophageal reflux disease, should we adopt a new conceptual framework, that was published in the American Journal of Gastroenterology. And I think this paper brought to the front the important concept that movement in between phenotypes of GERD is very limited. And it was very important to know because it has a tremendous impact on our clinical practice. Here's some of the figures that were published in different papers related to this one. For example, the three phenotypic presentations of GERD, and the fact that there is very little movement in between these different phenotypic presentations, either from progression or regression. I spent a tremendous amount of time studying and trying to understand why patients do not respond to anti-reflux treatment, specifically patients with gastroesophageal reflux disease, what is now called refractory GERD or PPI failure. And this is one of the first papers that in fact summarizes the concept of PPI failure in patients with gastroesophageal reflux disease and putting together all the potential underlying mechanisms. This is, to me, one of the important studies that we've done in the area of refractory GERD. This was actually the first study that compared patients who were successfully treated with PPI to those who failed PPI treatment. And this is a more recent study showing that many of the refractory GERD patients with documented GERD, the reason for the refractoriness is an overlap with a functional esophageal disorder. Obviously, as somebody who spent much of his career studying gastroesophageal reflux disease, I've had interest in various diagnostic tests for GERD. But one of the areas early in my career that I looked at was the impact of the test itself on reflux-provoking activities, specifically pH testing. Noticing that many patients did not tolerate well the pH test resulted, obviously, in a study trying to understand what is the extent of the impact of the test on patients' reflux-provoking activity. And I was able to demonstrate that in the study that was published in Digestive Disease and Sciences. For example, here on patients' discomforts, effects on sleep, nutrition, as well as others. This study was perfect in a way that it was published before a new type of technology was introduced, which was the wireless pH capsule. And one of the basic concepts behind the wireless pH capsule was the fact that it takes away the probe effect on patients' reflux-provoking activities. I've spent about a decade trying to understand the relationship between sleep and gastroesophageal reflux disease. This is, for example, one of the early studies where I looked at the connection and the relationship between obstructive sleep apnea and gastroesophageal reflux disease, published in Clinical Gastroenterology and Hepatology. In the journal Chest, I looked at predictors of heartburn during sleep. And in the Journal of Clinical Sleep Medicine, I looked at the relationship between sleep quality and pH monitoring findings. I also looked at the distribution of acid exposure during the sleep period in the different phenotypes of GERD, as it was published here in Elementary Pharmacology and Therapeutics. And also proposed that we should analyze pH testing or impedance plus pH, not based on the fact if patients are supine or upright, but rather if the patients are asleep or awake. Later, as a team, we developed a new way to evaluate patients' sleep experience at the time that we evaluate their acid reflux experience using integrative actigraphy and pH testing technology. This is, for example, some of the studies that we published at the time, looking, for example, the impact of supine awake and conscious awakening periods on acid reflux characteristics, published in the American Journal of Gastroenterology. The impact of how long you're awake in your bed before you fall asleep, like in this study, or what we call riser's reflux, the effect of coming out of sleep in the morning, as it was published in Neurogastroenterology and Motility in this paper. But one of the important areas that I was also interested in use the sleep studies to further understand is silent reflux, as we did find that patients would have experienced reflux episodes, wake up because of these reflux episodes, but would not experience symptoms or typical GERD symptoms. I've also developed this model, the bidirectional relationship between sleep and GERD, showing the relationship between poor sleep and GERD and severe GERD and sleep. We've also studied the effect of napping on gastroesophageal reflux disease, clearly showing that napping in patients with gastroesophageal reflux disease could be associated with severe reflux events. And this was a summary paper that I wrote recently with Dr. Bill Orr, as well as others, that was published in Lancet Gastroenterology. I was also involved with Dr. David Johnson in writing the sleep and gastrointestinal health chapter in the sleep textbook. I was also intrigued by Barrett's esophagus pathophysiology and why patients develop Barrett's esophagus, and I was trying to understand it. Early in my career, I was able to demonstrate that there is a correlation between the length of Barrett's esophagus and the level or degree of esophageal acid exposure in a paper that was published in Gut. And I was clearly convinced that to understand why patients develop a certain length of Barrett's esophagus is the key to understanding why patients develop Barrett's esophagus. And so I worked tirelessly in trying to understand the relationship between different factors and length of Barrett's esophagus. And you can see several publications here related to this topic in journals like the American Journal of Gastroenterology, Gastrointestinal Endoscopy, and others. We've even developed a predictive model for length of Barrett's esophagus using Hill hernia length and duration of esophageal acid exposure, and showing how accurate this model was. I spent a significant amount of my time designing a variety of phase 4 PPI trials, now also involved in designing pivotal trials with PPIs as well as PCABs. Here are two examples of papers, one with dexlansoprazole and another one with a medication called VCAM, which is a combination of omeprazole and succinic acid, a medication that eventually did not end up in the market. This is a recent work that was done with vonoprazan, specifically looking at non-continuous treatment in patients with non-erosive reflux disease using an on-demand vonoprazan. My current new areas of interest is I still remain interested in many of the areas that I've already mentioned. In the last few years, I've had also some new areas of interest. For example, I'm very interested in women's hormones and their effect on gastroesophageal reflux disease. And you can see two recent publications, one in clinical gastroenterology and hepatology, and the other one in neurogastroenterology and motility, as well as also recent work in autism and its relationship to gastroesophageal reflux disease, as well as other DGBIs. These are two important reviews that I was involved in writing recently. This one in Nature Primer, a very extensive review on gastroesophageal reflux disease, one of the few reviews that looked at patients from the time they were born and until they die. So it covers the whole gamut of patients' life and how gastroesophageal reflux disease affect those patients. And I was also involved in writing the clinical practice for New England Journal of Medicine, a paper that was published last year. These are some photos from the recent Rome Foundation meeting. It was during the DDW, and this is after receiving the Aldo Torsoli Award. On the left side, I was lucky to receive it this year with Professor Corsetti, and I was also very lucky to have my son, who is also a gastroenterologist, being present during the award ceremony. So I would like really again to thank for giving me the Aldo Torsoli Award. As I said, I'm honored. What a prestigious award. Thank you.